Welcome to Audio Companion for CSAP 17. This is John Weigelt, your Medical Director of Audio Companion for CSAP 17. CSAP 17 is the major CME product of the American College of Surgeons and was just released at the ACS Clinical Congress in San Francisco. CSAP 17 has some major changes in how the material can be used as a learning tool. However, CSAP 17 would not be complete without its audio companion, CSAP 17 Audio Companion. The Audio Companion is now in its 7th edition since starting with CSAP 11. CSAP 17 remains the backbone of CSAP 17 Audio Companion. I use questions from the various categories of CSAP 17 to craft an interview with a CSAP author whose primary clinical activity resides in the category we are discussing. While that is my plan, I never stay completely on a script. I have many opportunities to touch on related areas with my experts that do not appear in CSAP 17. I try to explore topics that generated a lot of discussion within the CSAP 17 committees, asking our expert to weigh in with his or her ideas. A recent addition to my interview is to use material appearing in the ACS general surgery communities that were discussed by many CSAP committees. I seek clarification of these topics using my CSAP author. These discussions allow me to bring in new information, often published since we finished writing CSAP 17. Medical information continues to change at a rapid rate, and this is my small attempt to have CSAP Audio Companion stay abreast of this rapidly changing landscape. My overall goal with these interviews is simple. I encourage the CSAP authors to provide their insights into the topics while applying the content evidence. Thus, I end up with a nice blend of evidence and experience. As we know, we often depend upon experience in medicine, as the exact evidence we crave is not available. That experience is clearly evident when I get our experts to comment on how they do things when reviewing a surgical procedure. It also surfaces when we review patient scenarios about a specific problem. I'm sure you will find many of these discussions interesting and useful. Finally, you will note that I often use more than one author interview to cover a specific topic. I do this especially where there appears to be a number of different views. I find it interesting that in most cases, the difference in viewpoint or the controversy is very small, despite how great the differences sound in the literature. Another finding in controversial discussions is the emphasis CSAP authors place on a collaborative effort for final decision-making between surgeon, other physicians, and their patients. It is clear that our CSAP authors are directly involved in difficult patient decisions, similar to all of our listeners. A favorite question I get asked is how the ACS CSAP and Audio Companion for CSAP should be used. They are different but complementary. The format is clearly different. Audio learners may find Audio Companion to be their favorite, but self-assessment is easier with ACS CSAP. Questions used for CME credit are different between the two products. Answer explanation is more complete in the ACS CSAP. Experience comments are probably more common in the CSAP Audio Companion. I obviously recommend both products. I believe neither will disappoint you. Different learning styles abound among all of us. How you use either or both of these products is your decision. All I can really say is that both provide an opportunity for lifelong learning. Well, enough of my chatter. I welcome you to CSAP 17 Audio Companion. Good listening, good learning. I'm sitting here today with Dr. Dan Vargo, who's one of our CSAP 17 authors. Dan, let's start by asking you to share with our audience where you're located, your primary focus of your clinical practice, and maybe a little bit of how you spend your usual day or week, if there is one of those.
Well, thank you, Dr. Weigelt, and I want to thank the CSAP committee for allowing me this opportunity to chat with you today. I am a professor of surgery at the University of Utah in Salt Lake City. I spend my days doing basic general surgery in addition to doing complex abdominal wall surgeries, reconstructions, and fistula takedowns and such. I split that time with my program director's role, running the general surgery residency program here at the University of Utah, in addition to running the simulation program.
I've got to tell our audience, if they haven't talked to a program director in the recent years, being a program director is a full-time job as far as I'm concerned. So I applaud you very much for doing that job and helping train the future generation of surgeons. So thank you.
I appreciate that. Thanks.
I have asked you today to share some of your thoughts with conditions that a general surgeon faces. And I'm going to lean on your expertise, especially in abdominal wall problems, to discuss some topics from CSAP 17 that are located in the abdomen and alimentary categories. Some of the topics actually come from CSAP 17 questions, and others are from questions that were written and discussed by the committees, but didn't make the final draft. But for some reason, they stuck in my mind as questions where the discussion was robust, and therefore I think I want to get your idea of what you think about the topic. So let's get started. I am going to start with abdominal wall hernias, but maybe in a little different place. And I want to ask you about technology. We did have a fair number of questions regarding new technology in CSAP that were discussed by the various committees. And first, should I or should everyone expect that laparoscopy be the way that we should be fixing a straightforward inguinal hernia?
Well, that's an interesting question because it really does get to where a surgeon's talents lie. There are general surgeons who were trained with laparoscopy, did a fair number of laparoscopic hernias during their residency or in their early years in practice and have become very familiar with that technique. There are other general surgeons who now seem to be more my generation and a little bit older, who came through training when laparoscopic inguinal hernia specifically was just starting to be popularized and were much more facile with the open technique. If you look at the literature, there's no real outcomes difference between the two techniques. Laparoscopy does show decreased pain and earlier ability to get back to full mobility, but the limitations of both of them are the actual healing of the mesh in place. So I think that hernia repair should be done by the technique that the surgeon is most familiar with, and that would be for a primary inguinal hernia, and with a little bit of a lean maybe to a younger patient being considered for a laparoscopic approach just because of the earlier return to activity.
What about ventral hernias? Same comments?
I think ventral hernias may be a little bit different. There are definitely more issues that can arise after you do an open ventral hernia repair versus a laparoscopic ventral hernia repair. You have a bigger wound, so there's more chance of getting infection after the procedure. Not a mesh infection, but just a garden variety soft tissue infection. There's also a significant increase in the amount of pain associated with an open repair. my take on doing ventral hernias is to always think about a minimally invasive approach, unless it's something very small, like an umbilical hernia or an epigastric hernia.
All right, now I'm going to lean on your knowledge about abdominal wall problems as well as your role as the program director. I think we all know that open procedures, open AAA repairs, some people would say open trauma cases, and recently there was an article about the lack of training regarding axillary lymph node dissections. So I'm going to ask you from a training perspective, is the open approach going to be part of our history because it's just not being done anymore?
I don't think so. I think there are always going to be situations where you have to consider doing an open approach. For example, if you have a patient with a loss of domain type hernia and you're going to be excising a fair amount of at-risk skin at the end of the procedure, or if you have somebody with a skin graft on their abdominal wall that you're going to be excising as part of their hernia, or if you have somebody who has an intercutaneous fistula that involves either the hernia or tissue adjacent to where the hernia is at, and you're going to have to do an open procedure to take down their fistula. I think all of those situations are still prime candidates for an open procedure. And so when physicians are thinking about approaching a hernia and the type of approach they're going to use, open has to be part of that discussion. If you have to do anything inside the abdomen other than fix the hernia.
It sounded like most of those conditions apply to ventral hernia repair. What about inguinal hernia repair?
I still think there is going to be a role for open inguinal hernia repair because the teaching that we use here at Utah and that I follow personally is you have two spaces that you can put mesh in the groin. You can either put it anteriorly or in the preperitoneal space, and laparoscopy uses the preperitoneal space, and if somebody gets a recurrence, then the technique that we always recommend here would be to do an open procedure. There may be some folks who are skilled with laparoscopy and can get back into the groin area and perform a repeat laparoscopic procedure. Say if they did a TEP the first time, they could try and do a TAP the second time. And others who utilize the surgical robot to accomplish those same things. But that seems like a kind of a long run when you have a perfectly fine, undisturbed space to be able to try and repair a recurrent hernia. So I still think there's going to be a role for doing open inguinal hernias because we are not perfect with our minimally invasive approaches.
Well, you brought it up even before I asked the question, so I see a lot of inguinal herniorrhaphies being done with the robot. Is that something we should be promoting?
That's a very interesting question because it gets to where is this technology heading. If you look historically at specialties that have adopted the robot fairly significantly, for example, urology, those specialties have had a deterioration in their laparoscopic skill set to the point now where procedures which are probably reasonably well done laparoscopically are done robotically. For general surgeons, the procedures that we talk about potentially being advantageous with the robot are low pelvic dissections, low anterior resections, APRs, and such. And those are fairly technical procedures. I envision robotic inguinal hernia repair as being kind of like training wheels, where you're starting to learn your skill sets that you can then apply to a more advanced procedure. And it's no different in my mind than doing a laparoscopic cholecystectomy and then doing a laparoscopic inguinal hernia repair and then moving on to doing laparoscopic right hemicolectomy and then laparoscopic adrenalectomy. You kind of add complexity as you go along. And if the only case that we do as general surgeons is going to be difficult pelvic surgery with the robot, then how are you going to be able to train somebody to be able to do that? I think a robotic low anterior resection, for example, is within the realm of a general surgeon. You don't need to be a colorectally trained person to be able to do that operation. And we have to have ways to be able to train our residents to be able to perform those types of procedures. So I do think there's a role for the robot. Do I think every single inguinal hernia operation should be done with the robot? Absolutely not.
You mentioned you were also involved with your simulation lab. Is the robot part of your simulation lab?
It is part of our simulation lab. We have a curriculum for our residents to go through with regards to robotic surgery. We don't do procedural-based simulation currently. We just do exercises like we do with FLS and FES, with the idea that there is no really good, true, full procedure simulation on the robot as it exists. Let's
stay on inguinal hernia for a while. And there's been a lot of changes in the last two issues of CSAP regarding the management of a male patient with a small asymptomatic inguinal hernia. And I distinctly remember discussing this topic with you for CSAP Audio Companion 16. So let me ask you, has your approach changed as the data continues to evolve?
My approach has changed a little bit. There has been a number of follow-up studies since Fitzgibbon's first published Watchful Waiting in 2006, and he actually has a publication in September 2019 in Advances of Surgery where he reviews all of the studies on watchful waiting, and it's pretty consistent that at 10 years, 75% of patients are going to ultimately need to have their hernia repaired. And for me, this means that if you have a healthy 24-year-old who comes in with an asymptomatic hernia, which would be relatively straightforward to repair at that time, why would you let that patient continue on to get a larger hernia, potentially change your approach to trying to repair said hernia? Why wouldn't you just offer that person a repair with the understanding that, he is more than likely going to require a repair? I've taken that approach with pretty much everyone under the age of 60 right now. And then over the age of 60, depending on whether somebody is going to be traveling to some place where care is going to be difficult to receive. For example, we have a lot of retired people who are volunteer park rangers in the West, and they're up in the backcountry, a day-and-a-half hike from civilization. And if that person comes in with an asymptomatic hernia, I'm going to repair that, because if they get a complication from the hernia, that's pretty devastating for them. So I would say that my approach has evolved over the last 3 to 4 years. I'm offering surgery to more people who I wouldn't have offered surgery to in the past, but I also still have a discussion with the patient and let the patient make a decision at that point. I don't just say, well, it's asymptomatic, you don't need it fixed. I say it's asymptomatic, it's probably not going to cause you any problems, but you may want to consider getting it repaired because of some specific factors.
What if the patient is female?
Well, that's an interesting topic also. If you go through the literature, there's no good literature on watchful waiting in females. And the classic teaching for us as general surgeons is if a woman has a hernia, they need to have it fixed. But I think that's more predicated on the fact that femoral hernias are more common in women than they are in men, even though inguinal hernias are still the most common hernia in women. So if a woman comes in and has an inguinal hernia and they're young, I'm going to provide them the same advice that I would provide to a male. If a woman comes in and they're older and they have an asymptomatic hernia and the ring feels fairly large on examination, then I'm going to probably talk to them more about watchful waiting, especially if they're not all that physically active and they're not getting themselves out in the hinterland. So I really do try and tailor my discussions, but I don't really change my discussion between men and women.
Then the next issue when we start talking about female inguinal hernias is, do you alter your repair?
The only thing I really alter with a female is the ligation and transection of the round ligament. That's a standard part of the procedure that I perform. There was some concern that there would be an increased incidence of pelvic organ prolapse with that approach, but that's been dispelled by a couple of papers in the literature that have been recently published. I'm more likely to try to close the defect in women before placing mesh, and my approach is going to be the same for most younger people. I'm going to do a laparoscopic approach. For bilateral hernias, I'm definitely going to do a minimally invasive approach. For an older patient who doesn't necessarily need to get back to activity as quickly, I'm probably going to do an open approach on that. But a lot of that is also based on resident benefit because we are doing fewer open inguinal hernias, and I do feel that our residents still need to learn the open approach.
So you do use mesh when you close the ring on a female?
Yes.
Oh, okay. And where do you anchor it? Same place as in a male?
It depends on the size of the hernia. So there is a good body of literature that basically says that smaller hernias done with a minimally invasive approach do not need to have their mesh anchored. There is a categorization out of the European Hernia Society that talks about larger direct hernias, and in those patients you should fix the mesh in place. There's some arguments about how the mesh should be fixed into place, but at minimum there should be a suture placed near the pubic tubercle and then potentially sutures or tacks away from the triangle of pain and triangle of doom.
All right, well, still in the same area, but a different topic. So sports hernia disappeared from CSAP 17, although I do note that there is a session at the Clinical Congress this year on that topic. So where do you stand on this diagnosis?
Well, it's funny that you should ask because I am the sports hernia specialist at our institution.
Okay.
It is also an interesting topic because of its title. A sports hernia is not a hernia per se. And the term that we use, sports hernia, actually encompasses probably 3 separate entities that occur in the groin. When we talk about a sports hernia, we're typically talking about a weakness of the inguinal floor, and a patient will get symptoms because it compresses one of the nerves in the groin. Technically, there's not a defect there, but if you do a Valsalva ultrasound, you can see a bulging of the inguinal floor. And when you examine the patient with that type of pain and you put your finger through their external ring and palpate their inguinal floor, it reproduces their pain. And those are kind of the classic findings of a sports hernia. And those are people who get repaired just like a normal hernia would be repaired. You could either do an open or a minimally invasive approach, and the vast majority of those folks are going to get better with that procedure. The other issues that come up with groin pain that aren't sports hernias are things that revolve around the pubic tubercle. So athletic pubalgia, where people disrupt the musculotendinous junctions from the pubic tubercle, or the adductor tendons of the thigh from the pubic tubercle, are the other 2 things that we see. And those are patients that will typically refer to physical therapy. There are several good programs that you can look up online and download and then provide to a physical therapist to place somebody into a protocol. Ours here lasts for approximately 8 weeks, and the vast majority of people don't end up needing surgery. That problem tends to be more of a musculotendinous imbalance that once you correct it, people don't need surgery for it. So
sports hernia is a conglomeration of various problems that produce similar symptoms. Is that fair?
That's fair. It's kind of like irritable bowel syndrome.
Okay. All right.
It's kind of the way that I look at it.
All right. Well, let's talk about ventral hernia. And to do that, I'm going to give you some different defects, and why don't you tell us how you would approach each of them? So let's start with a female patient with a small 3-centimeter umbilical hernia. Comes to you because she's got a protrusion and wants to know what you would recommend.
For a 3-centimeter hernia, I would recommend doing an open approach. And if it truly was 3 centimeters at the time of surgery, then I would end up placing a mesh at that time. Anything over 2 centimeters probably should have mesh placed. And the mesh would be placed where? Well, it gets into a good question about nomenclature, about where do we place mesh. I think the two that you can eliminate right away would be an onlay mesh where you place mesh on the anterior abdominal wall, and an inlay mesh where you place mesh in a bridged position between the muscles without reapproximating the defect. So that leaves either a sublay or preperitoneal mesh or intraperitoneal onlay mesh. And for an umbilical hernia, you should be able to generate enough of a pocket in the preperitoneal space just with some blunt dissection that you can place mesh into the preperitoneal space and then close the fascia. So your break point to use mesh versus no mesh is 2 centimeters? Correct. Is 3 centimeters wrong? I don't think 3 centimeters is wrong because it gets to, if it's 2.1, how different is that from 2.0? I think there are people with 3-centimeter defects and certain body habituses that you would definitely think about putting mesh in, and there are people with 3-centimeter defects with other body habituses that you would think not to put mesh in. And obviously this is all done in consultation with the patient, because if a patient has a 3-centimeter defect and has a big aversion to having mesh placed, then I don't think it's wrong to do a primary repair for a 3-centimeter umbilical hernia. The next patient's a young male with a 2-centimeter diastasis from the manubrium to the umbilicus. That would not get repaired. That would be a cosmetic defect, and if the person was really concerned about this diastasis, I would refer them to plastic surgery to have a consultation with them. So no need to try to mobilize the rectus muscles to resolve this 2-centimeter diastasis? No, there is no current indication outside of cosmesis for repairing a diastasis. There are some patients who come into clinic who have diastasis and have pain associated with the diastasis. And in that situation, one could potentially have a discussion with the patient about repairing it, but you'd have to be very, very certain that this was a disabling pain associated with the diastasis. I would say that in 20 years of doing this, I have primarily repaired one patient with diastasis, and it was like 7 or 8 centimeters. It was significant diastasis in their abdomen. Well, how about a middle-aged female with a right upper quadrant hernia after an open cholecystectomy 20 years ago? It would depend on what was left of their right rectus muscle after their right upper quadrant incision was made. The two situations you run across with patients with hernias after having right subcostal incisions are those where the rectus muscle is intact and the rectus muscle is missing or atrophied because it was denervated with part of the procedure. If you have somebody who has a rectus muscle that's intact, then you can perform a retrorectus repair in that patient, and that can be done either laparoscopically, robotically, or open. But your ideal place would be to place the mesh in the retrorectus space, so take down the rectus sheath, suture the hole closed in the rectus sheath, and then place mesh into that space. If the patient has atrophy of the rectus muscle secondary to their right subcostal incision, then my approach for that patient is probably going to be a laparoscopic or a robotic repair, trying to primarily close the defect and then place mesh intraperitoneally. And when you place mesh intraperitoneally, do you use any kind of special mesh that doesn't cause adhesions? We will always place an adhesion barrier mesh when placing it in the abdomen. I don't think that there is a situation where you would place a mesh without an adhesion barrier into the abdominal cavity.
Well, how about a 65-year-old male with a 6-centimeter ventral hernia after an open AAA repair about 7 years ago?
If that was that patient's only previous abdominal surgery, then I would try to do this procedure with a minimally invasive approach. One approach would be to do this straight laparoscopic. You can attempt to try and close the defect after you get all the adhesions and everything taken down, and then place mesh intraperitoneally. Alternatively, because it is less than 8 centimeters, you could try and do this via a retrorectus approach robotically. And that's become kind of the new sexy way to try and fix these types of hernias, in that you don't have to worry about the adhesions and so forth that are in the abdominal cavity because you're just accessing the retrorectus space with the scope and then developing that space and then repairing the hernia via that technique. And for people who are interested in reading a little bit more about that, there was a really nice review article in Current Problems in Surgery last year that was published by Adrian Park.
And what about a 10 centimeter? Does that even create another situation and another approach?
It does. Anybody who has a hernia that's greater than roughly 8 centimeters, you need to be considering a component separation on. And again, that procedure can be done either open or via a minimally invasive approach, but greater than 8 centimeters is going to more than likely be a component separation.
How about a ventral hernia with Swiss cheese defects all along a midline incision?
So with that patient, again, you could either do a laparoscopic or a robotic approach. That would be my first approach for that patient. With the laparoscopic approach, it would depend on how many previous operations the patient had had, but it's fairly easy to completely clean off the midline in that situation. Then you can try and close the midline, which would be more difficult in this patient because you'd end up having to reapproximate the entire midline laparoscopically, which would be difficult. Alternatively, you could do an intraperitoneal approach with the robot where you could close the midline defect. Even a full-length midline defect can be closed robotically fairly easily, and then place an intraperitoneal mesh. And alternatively, there is still the retrorectus approach, again, typically done with the robot.
We haven't talked much about it, but when you're putting this mesh in, especially in the midline, have we come to an agreement on what the best length of overlap there should be between where your hernia defect is and where you're going to extend the mesh laterally on each side?
Yeah, I think we're still at 5 centimeters. That would be the optimal distance. There are people who say you should go as wide as humanly possible, which if you're intraperitoneally, I mean, that could be from the left to the right white line of Tolt, but that doesn't make any sense to me. 5 centimeters still is pretty much the standard.
Now, there's some people who say 3 centimeters is okay.
Yeah, I have not seen good randomized controlled trials that have looked at 3 versus 5. If they exist, I'm not aware of them. I do know that most of the review articles currently still use 5 centimeters as the standard.
One more. So a ventral hernia after a Phalansteal operation. Never occurs, I know that, but let's pretend you've got one.
So a Phalansteal incision is an interesting incision to have a hernia associated with it. You have a very large retrorectus space, and you have good anchor points down below to Cooper's ligament. So my approach for that would be to access the retrorectus space by either laparoscopy or robotically to close the defect, and then to anchor the mesh down to Cooper's ligament bilaterally to get inferior fixation, and then transfascial sutures on top. If the hernia was big enough that you didn't feel comfortable doing that, you can obviously do that open. And it's a space that we as general surgeons should be very familiar with from our inguinal hernia repairs.
Well, I knew you would mention meshes as we went through all these patients, so I'll ask the first question. Is one type better than another?
Short answer, no. When you think about meshes that we currently use, they're basically made of either polyester or polypropylene. So polyester tends to be not used as much. Polypropylene tends to be used a little bit more frequently, but that's more based on marketing. And then each of those meshes have multiple vendors who sell it. And each of them have multiple permutations of medium weight, lightweight, heavyweight, no weight, and so forth. If you had to pick out mesh for your institution, you'd want to pick out a medium weight polypropylene or polyester mesh and then have one flavor that had a barrier on it and one flavor that didn't have a barrier on it. And I would choose the vendor who had the best price.
And does the type of barrier make a difference?
Currently, it does not. There is no real good randomized literature that looks at the type of barrier. There are meshes that have Sepra film that is bonded to the back of the mesh. There are others that use oxidized cellulose. All of them have patients that they work well in, and all of them have patients where you go back in and you wonder why they didn't use a barrier mesh because the barrier didn't work at all. And we still haven't been able to figure out why that is. It obviously has something to do with maybe the degree of inflammation that occurs after surgery, and if that inflammation overcomes the barrier, then you get adhesions to the mesh. If there's a small intra-abdominal infection, maybe there's adhesions to the mesh, but we just don't have a good understanding of why these things happen.
So with all of them being about equal, is there any differentiation when you talk about specific situations in a patient, infection, fistula, anything, or are they still all about the same?
Well, when you start getting into the more complicated hernias with fistulas and contaminated fields and so forth, then you have to start asking yourself whether you would want to use a bioresorbable or slowly resorbable mesh, or you'd want to use a true biologic mesh. And there are situations where I would consider using one versus the other. At our institution, we have moved away from using a lot of biologic mesh. We typically will use that as a temporary abdominal coverage in abdominal catastrophe type situations. But outside of that, we will typically end up placing a slowly resorbable mesh, assuming you can get the abdominal wall put back together. You can't use a slowly absorbable mesh as a bridge. So if you think you're going to have a bridge to repair and it's contaminated, then that would be the one situation where you'd want to use a straight biologic mesh.
And the costs of the biologics are coming down?
They are coming down. Depending on your contract with your vendor for your biologic mesh, in some situations your biologic mesh could be less expensive than the slowly resorbable meshes. And then you have to balance it off against potential complications and so forth from using each of those meshes.
Well, now you've already insinuated we have a problem with nomenclature for mesh placement. And I will agree with you that many of the CSAP committees have had a difficult time on coming from various institutions and then agreeing on the nomenclature that we were going to use as we developed a CSAP 17 question. So can you give us your update on nomenclature for the position that we now place mesh in?
Sure. There was an article published in 2017 in the World Journal of Surgery that is titled Nomenclature in Abdominal Wall Hernias. And it is basically a consensus statement about how they would like to have the position of the mesh documented in any manuscript that gets submitted for publication. And they have basically 5 areas that mesh can be implanted. One is as an onlay, where you place the mesh onto the anterior abdominal wall after closing the fascia, and the mesh sits on the anterior rectus sheath. There is an interposition or inlay, where the mesh is a bridging mesh sutured to the fascial edges. There is retrorectus or sublay, where mesh is placed in front of the rectus sheath but behind the rectus muscles. There is underlay or preperitoneal, where mesh is placed into the preperitoneal space. And you can see how retrorectus and preperitoneal can merge into one category when you get below the arcuate line. And then there's intraperitoneal onlay mesh, where mesh is placed in the abdominal cavity. So those are the 5 areas and the 5 descriptors that we should be using for placing mesh.
On the communities, and actually within CSAP 17, there is a discussion on anterior and posterior component separation to repair abdominal wall hernias. And as usual, there's pros and cons. So I guess my first question is, do you have an opinion?
I do have an opinion. My approach for component separation is to approach it with a posterior component separation. The reasoning behind that is, one, you don't need to make big skin flaps if you're doing that procedure. And second is, if somebody gets a hernia recurrence after you do a posterior component separation, you can always do an anterior component separation afterwards. So it does leave you a backup plan if you need a backup plan. So those would be my reasons for doing a posterior component separation.
And your exposure as you do that posterior component, do you want to give us some idea how you get there?
Posterior component separation is basically an extension of the retrorectus approach for doing a ventral hernia repair. You make an incision along the undersurface of the rectus muscle along the medial border of the posterior sheath, and then separate the posterior sheath from the overlying rectus muscle. You'll come across some small mid-muscle artery and nerve perforators at this level, and those are not the real nerve and blood supply to the rectus muscle, and so you can actually take those down with cautery. And then you will come to the semilunar line, and that is the area where you would make an incision in the posterior rectus sheath just medial to the semilunar line. The semilunar line is where the innervation and blood supply to the rectus muscle really comes from, in addition to the blood supply from the superior and inferior epigastrics. And if you denervate that at that level, then you'll end up with a defunctional and dead muscle. So you stay medial to that, and I typically make that incision up where the transversus abdominis muscle is, because then you come through the transversus abdominal muscle and you're sitting on top of the peritoneum, and that's the plane that you want to be in. And so that's where the other name for posterior component separation comes from, which is a transversus abdominis release, or a TAR.
Well, the other discussion that happened on the communities was related to the anterior approach, and as you mentioned, the large skin flaps that are often needed. And somebody mentioned using a sclerosing solution to prevent seroma formation. And any thoughts on that?
I have been involved in trying to do these abdominal wall reconstructions since about 2000, and I have seen a lot of different things done to try and prevent seroma formation. I have seen talc put into that space. I have seen Bacon solution put into that space, anything to generate an inflammatory response to try and decrease seroma formation. And at least in my experience, I have not found any of those to be particularly useful. The one technique that I have found to be somewhat useful is to do something called a progressive abdominal wall closure, where you basically take stitches and put it between the anterior rectus sheath from below and the fat from above, and you suture things down from lateral to medial. And it's a technique that plastic surgeons will typically use. and then they will intersperse drains in between each of those layers of closure and then put a binder on the patient after they're done completely closing. There is a little bit of literature that supports doing that. If you think about it, after doing a long component separation, you're then going to spend an hour and 15 minutes to close the abdomen. It can be a little bit daunting to think about doing that after doing, say, a 4.5 hour abdominal wall reconstruction.
I hate to go back to history, but isn't that what our forefathers in surgery called closing the dead space?
That is correct. That is closing the dead space. But now it has a fancy new name for it, which is a progressive abdominal closure.
And it probably has a code.
If it's done by plastic surgery, it probably does have a code.
Okay. All right. Well, let's talk about another use of mesh, and it's again a change, and that is the use of mesh when constructing an ostomy. Is this something you do?
It is something that we do. We have just started off a formal protocol to identify patients who would benefit from mesh placement at the time that they have a permanent colostomy performed. And the reason we made this decision was Cochrane Review in 2018 looked at mesh placement for prevention of peristomal hernias, and their conclusion was that there were no increased complications with the placement of mesh, and there was a significant decrease in the peristomal hernia rate in patients who had mesh. So based on that, we are approaching people who are having permanent colostomies with placement of prophylactic mesh.
And what about the patient that comes in with a peristomal hernia? Do you repair that and put mesh in?
Yes. We do a sugar baker technique and do it in such a way that we take a second piece of the barrier mesh that we use and fashion basically a little tube out of it to put over the bowel, and then put the mesh over the top of that little tube of mesh. That way we don't have polypropylene right up against the bowel coming through the abdominal wall.
So in other words, this, from what you described previously, this is mesh that's placed intraperitoneally when you do this.
Correct. My approach to repairing peristomal hernias is to approach them with an intraperitoneal approach and to do a sugar baker repair.
Well, I think we've beaten the hernia topic up pretty good this morning, but one more question. So when you have a hernia, a ventral hernia with a GI fistula in the picture, and you've done all the tricks that you know to close the fistula, but it persists, what do you do?
Well, in that situation, at the time that you're going to be operating on that patient to take down their fistula, that would be considered to be a contaminated case. And there is some literature that supports using biologic mesh in those situations where you have a reasonable chance at both taking down the fistula and repairing the hernia if you use biologic mesh. And again, the reason is just to avoid getting a mesh infection in a contaminated field. There is some data that's starting to come around, and I think there's going to be something presented at the college about using slowly resorbable mesh in those situations if you can get the abdominal wall completely put back together. But I would consider one of those techniques. I would not use a prosthetic mesh after I took down the fistula.
I should have asked this question before, but it just struck me that I'm not quite sure I know what slowly absorbable mesh is made out of.
I don't know the exact chemical composition of each of the slowly resorbable meshes that currently exist. Two companies make the mesh. They both are a little bit different. I do know that one of the meshes resorbs by something called zero-order kinetics, so it is not absorbed faster in the face of infection. It has a very predictable timeline that it goes away. And it's basically an enzymatic reaction in your body that slowly resorbs the mesh so that you're left with no foreign body in your abdominal wall after it completely goes away. There are some other products which have PDS as one of their components, but still have mesh associated with them. And those products do leave behind some foreign material, so it still puts you at risk for having a longer-term complication from having a foreign body in your abdominal wall.
Have to look into that just for my own edification, let's put it that way. So, okay, well, that was my last hernia topic. So let's talk about another problem that I'm sure you see as a general surgeon, and that's a rectus hematoma. And can you kind of give us a profile of what kind of patient we would expect to see this in?
Yeah, it's an interesting problem, and it's a problem that has evolved over the last several years. Rectus sheath hematomas used to be thought of as just being due to trauma. You think about your lower abdominal wall and where your inferior epigastrics come in. They're fixed to the lower abdominal wall, but they give off little side branches that can be torn, and either trauma or vigorous coughing or so forth could cause that to happen. But now with what seems to be increasing use of anticoagulants, and specifically our novel oral anticoagulants, this is a problem that we're seeing in patients who don't have trauma to their abdominal wall, who maybe did just cough or sneeze and then all of a sudden started to develop a large, painful mass in the lower part of their abdomen.
Is this self-limiting, or do you sometimes have to do something about it?
It can be self-limiting, depending on where the vessel has been disrupted. There are patients who are actively anticoagulated, specifically with our novel oral anticoagulants, where you can't really reverse them very easily. And in those patients, sometimes you do have to provide an intervention for them. And that intervention is done by our interventional colleagues, either our vascular surgeons or interventional radiologists, where they can access the inferior epigastrics and then try and thrombose whatever's bleeding.
And after you've done that, is there any risk that you're going to end up having to evacuate that hematoma?
Only if the hematoma became infected would you end up having to evacuate it. I typically tell patients in those situations where they've stopped bleeding but they have a large mass in their lower abdomen that they're going to turn black, blue, and purple, and it's going to take a while for it to go away. But if they have any symptoms or signs of infection, that they either need to come in or be seen by me or by one of my colleagues and be evaluated to see whether they've developed an abscess in that area. Sometimes if it's a true collection of hematoma in that area and it's not distributed throughout the muscle, you can put a drain in it. If it's distributed throughout the muscle, sometimes you have to go in and then debride all of that.
Another hot topic for CSAP-17 was necrotizing pancreatitis. And I have already discussed the topic with a number of your CSAP colleagues on CSAP-17 Audio Companion to get their approach, but I want to ask what happens in Utah. So you have a firm diagnosis of necrotizing pancreatitis, but the patient is, I guess we would call it smoldering. They're still in the ICU. They don't look septic. They're maybe still ventilated, but they're tolerating support. What do you do with that patient? They haven't been instrumented yet.
Okay, so no drains, no nothing. They're just not getting better.
Correct.
Okay. Well, this would be a patient who, based on some prior CSAP work that we've looked at, would be a step-up type approach. This used to be thought of as being the panacea for all patients with pancreatitis, and this was a rapid approach to trying to get to the pancreas and debride the pancreas and so on and so forth. We've really pulled back on that a little bit and really do wait until somebody is in that really long, they're 2.5 weeks into their pancreatitis and they've really plateaued. And in that patient where you don't necessarily have anything to be able to drain, we would consider doing a step-up approach in that patient. If you do a CT scan and they do have something that's drainable, then I'd end up putting a drain in first, and then if they didn't get better after you placed a drain, then I would think about potentially doing a step-up approach.
that seems to be the question where people diverge, because some people say this is just a matter of advancing the drain and increasing the size of the drain, and others say that really the drain doesn't work and you really have to do a retroperitoneal exploration through the drain site using a scope. What happens in Utah in that situation?
Well, that's exactly what happens. Is that the radiologist will put a drain into the region around the pancreas, and then you just keep dilating that up until you can get it to the point that you can actually do surgery on it. And it is there are a few different ways of scoping the retroperitoneum to be able to allow that to happen. I know one of my more senior partners just takes the tract and reaches in with a pair of ring forceps and starts pulling out pieces of the pancreas. But if you can get it large enough that you can put a rigid scope back in that area and you can start to pick away at things with a rigid scope, that's probably going to be a little bit better way of doing things.
So that's really not what was originally reported as the step-up approach, which is what I'm finding interesting, because our experience is the same. Just putting the drains in doesn't seem to help that much, except to give you access to doing some kind of debridement. Is that a fair statement?
No, I think that's fair. And if you look through the current literature on necrotizing pancreatitis, what seems to be falling out is drainage, then a VARD, and then if a VARD doesn't work, then you would think about potentially, it's rare anymore, but you'd think about doing an open necrosectomy at that point.
Yeah, I think that may be a procedure for our history books.
Yeah, I think it's slowly becoming a procedure for our history books, that's for sure.
Okay, well, I'm back to the abdominal wall. Sorry, but I've got a wound closure problem. So I've got one of your CSAP colleagues who keeps trying to convince me that I should switch to small bites to close a midline wound. You got any thoughts on that?
I do have thoughts on that. This is a topic that about every 8 weeks on our service, when our chief and our fourth-year residents rotate off and new ones rotate back on, they have a list of topics that they can present at conference, and invariably they present the small bite study. I think that if you are operating on somebody for the first time, so let's say you're accessing their midline, you're going to do an open sigmoid resection for whatever reason. That patient population, it has been shown that they do have better outcomes with regards to incisional hernias if you do 5 millimeter back, 5 millimeter advancement bites. It's only 1 or 2 articles that has really been supportive of it, but the data on it is actually reasonable. The only not reasonable thing in those papers is the actual BMI of the people that were closed. It's typical Northern European literature, and so the BMI is low relative to, say, a U.S.-based population. So I have not seen data in people with a BMI over 35 who have been closed with this 5 and 5 approach. So I'd throw that out there as a caveat to anyone who's going to try this. The other caveat I would give is this is not for the patient who is having their 4th laparotomy and you have a difficult time identifying their fascial edges, or you took out a piece of infected mesh and you don't feel like closing the patient with another piece of mesh because of the infection and you're going to close them primarily. I think that's the wrong population also to try the stitch trial approach.
Do you use the stitch approach?
I don't do a lot of primary general surgery, so I don't use the stitch approach. Most of my patients are on their 3rd or 4th entrance into their abdomen. I will say that we have had 2 dehiscences here over the course of the last several months. One of them was with a 5 and 5 approach, and one of them was with a standard approach. So.
And your standard approach is what?
1 centimeter, 1 centimeter.
Okay, all right. And are you using running or interrupted?
Running, for sure. That's been shown definitively to have a lower rate of hernia and dehiscence And we also tend to use almost exclusively absorbable suture.
Related to the amount of foreign body in the wound, do you use a double-stranded that you loop for your securing first knot, if you will?
I don't, personally, and it's not just because of the amount of suture, it's how you have to tie them together at the end. This is totally surgeon preference because I don't think there's any real literature supporting one versus the other, but with the loop suture, you're supposed to, after you put your next to the last stitch in, you're supposed to cut one of the strands and then put another throw in and then tie the suture to itself. And then you do that from the top and the bottom. And to me, that always seems like you're leaving a little bit of a gap right where the two sutures are supposed to be.
I'm going to go back to mesh and abdominal wound closure when you use your closure, whichever, and that is, what do you think of the literature that says if we do an onlay mesh that we decrease incisional hernia?
I'm not convinced yet, unfortunately. I don't think that there's enough data out there to support using mesh primarily, especially in the onlay position. That would be concerning. And we've gotten completely away from doing onlay mesh for hernia repairs, and now we're going to do onlay mesh because it's easier to try and prevent hernias with primary fascial closures. And I am just worried about that. It bothers me a little bit.
Well, we'll wait and see what more data shows. So, and then the final one on wound closure is, where do you stand today on an incisional vax for your closures?
I think incisional vacs definitely have a place. We're not 100% sure what that place is. If you look at the cardiac surgery folks, they are putting incisional vacs on every sternum that they open and close. They're pretty well convinced that it does have an impact. We studied this a while ago and were able to show, at least in a smaller patient population, that it did decrease the amount of wound occurrences that we identified. It doesn't change the deeper infection rate, but it seemed to change the more superficial infection rate. So for me, if I have any sort of contaminated wound that I'm going to close, I'm going to put an incisional vac on them. And then the second population that I'll typically use an incisional vac on is somebody who's got a fair amount of sub-Q. So if you've got a bigger patient and you're going to close the skin and they have some risk factors for getting a complication such as diabetes or COPD or immunosuppression of some type, then I will use a wound vac on those patients.
And standard use of the wound vac is you change it how often?
I don't change it. We leave it on for 5 days and take it off on postoperative day 5.
And what if you still got a high drainage from the wound? Do you put another one on?
We don't see drainage from the wound when we use an incisional vac. The theoretical reason that we use an incisional vac is to increase blood flow to the wound. So typical vac physiology is that it's going to increase the amount of blood flow to the wound edges, and that's really what we're trying to do, is to use that vac physiology to try and increase the amount of blood flow to our closed wound. So there's not really much fluid at all that comes out. If you've closed the skin, there's maybe 5 milliliters, 10 milliliters over the course of several days.
Even in that patient who has that thick subcutaneous layer that you've just closed?
Well, it may be because I put in so many staples that I don't see a lot of fluid that comes out. I do have a partner who will close contaminated wounds with just loosely stapled, and we'll put a vac on it, and we'll change the vac out every other day for 3 changes. But that physician also is closing the wound rather loosely, and there is some seepage of fluid that the patient will have from their wound.
Well, let's deal with a relatively unusual problem, but it is addressed in CSEP 17, and that's a splenic cyst. So we have a young female with a splenic cyst that is complaining of left upper quadrant pain. Any thoughts regarding cause and management?
So you'd be describing a patient who has a non-parasitic cyst, I'm assuming.
Yes.
Yeah, so that would be the thing that we would see most frequently here in Utah. Those cysts can be caused by trauma, they can be caused by infarction of the spleen, and so forth. And for the most part, these types of cysts, if they're symptomatic, can be dealt with percutaneous aspiration. So you just take the fluid and you aspirate it out, and you don't leave a drain behind afterwards. So that would be our management strategy for a splenic cyst.
And if they recur?
If they recur, you could then re-aspirate them and try to use a sclerosing agent to try and get rid of the cyst. And then if they recur again, then you would think about potentially doing a splenectomy on the patient. But there should really be no reason to have to do a splenectomy. But I do understand that they do recur.
Okay, well, I see our time is about up. And it's really been a pleasure, as usual, spending some time with you, Dan, to discuss many of the CSAP 17 topics and some just topics that were discussed, but as I mentioned, didn't quite make the grade, I guess. So I'd just ask you if you've got any closing comments for our audience about the CSAP process or the process of CSAP Audio Companion.
Well, I will comment on the CSAP process. I think that the number of people who are involved in writing the questions, reviewing the questions, and the time that's involved, and specifically the time that you put into this, is a testament to the commitment of surgeons and their desire to provide material that people can review and update and so forth, and enhance their practices. If it wasn't for CSAP, for me, there would be a lot of things that I wouldn't necessarily be up to date on because there is so many things that we need to try and cover. And I find that CSAP does a very good job of just providing nice, concise, and literature-based content on those areas.
Well, I thank you for those comments. I also thank you for being one of the authors of many of those questions and that content. So I really do thank you for spending time with me from your busy day, and I hope you have a nice rest of the day. You take care.
Thank you, Dr. Weigeld.
Thank you, Dan.
That's the end of this session for this category of the CSAP 17 Audio Companion. This category will continue in the next session.